Rachel, are you going to start the meeting?
Yeah, I'll start with the introductions. Hi, everyone. Thank you for joining us today for our Psychopharmacology Consultation line with Dr. Kevin Hill and Dr. Matcheri Keshavan. I will be turning things over to them shortly, but first I'd like to review a few housekeeping items with you all. During the presentation, if you have any technical difficulties or questions about the topic, please use the chat or the raise hand feature during the discussion to have your microphone unmuted. The discussion is being recorded and will be available for reviewing at a later time on the MHTTC website. And to reach us afterwards, you can email newengland@mhttcnetwork.org. And with that, it is my pleasure to hand it over to Dr. Hill and Dr. Keshavan.
Thank you, Rachel. And it's my pleasure to welcome all of you to the fourth in the series of Psychopharm consult webinars as part of the MHTTC Mental Health Technical Assistance Center. I'm a psychiatrist at Beth Israel Deaconess Medical Center, and my colleague, Dr. Kevin Hill, is also a psychiatrist at my institution and is also a well-known expert in the area of addiction psychiatry. So I'll have Dr. Hill take the lead in today's presentation. He will tell us all about what's the current state of the art in managing people with comorbid substance abuse and psychiatric disorders. In this case, it's somewhat of a focus on psychosis. I'll join later on with some questions of my own, but there are some questions from the audience as well that we have received so far. But also feel free to add additional questions to the chat box, which Rachel will be monitoring, and so we will address those as well. So with that said, Dr. Hill, please go ahead.
Thank you, Dr. Keshavan. Thanks for having me. I'd also like to thank everyone for taking some time out of their busy Monday to join us, and hopefully we'll have a productive and lively seminar where we'll cover a lot of ground in a short period of time. And so my hope is that I'll run through a handful of slides, really sort of setting the stage, talking about what are the numbers for thinking about people who have co-occurring psychiatric disorders and substance use disorders, framing the issues that we all face when we try to treat patients who have these disorders, and then talking a little bit about the area that we're aiming on talking about today, which is pharmacology. So pharmacology of substance use disorder. So we'll talk about really the big three. I run a division of addiction psychiatry, and we treat patients with all sorts of substance use disorders, but really the three main ones that we encounter on a daily basis are alcohol, so alcohol use disorder, opioids in the form of opioid use disorder, and then cannabinoids. So it could be cannabis use disorder. We also treat patients who want to use cannabis therapeutically, and that's a whole nother issue. But we're going to talk today about what pharmacotherapies are available for those folks who have addictions, so use disorders with alcohol, opioids, and cannabis. And so I'll take the next slide, please. So as we talk about this, I mean, this is a huge issue. Really, when thinking about it, my goals are to try to help you understand this relationship between substance use disorders and any other psychiatric disorders. It could be psychotic disorders, as I know is a focus for this consultation line, could be mood disorders, anxiety disorders, etc. We see them all. And so I think it's important to recognize as clinicians, you don't have to develop a forte in all of these areas, but the goal of an event like this is to try to help you become more comfortable treating some of those issues which may not be your expertise, right? And so every day I'm treating patients with some psychiatric disorders that probably aren't the ones that I'm the best at, but we don't want you to make choices about who you treat based upon your comfort level with certain disorders. And so when it comes to substance use disorders throughout healthcare, frankly, a part of our job as addiction psychiatrists is try to help people learn how to get more comfortable. So we're going to want to do that today. So we want to help you understand what are the challenges, what things do you need to think about when you're treating somebody who may have a problem that is in your area of expertise, but also a substance use disorder if that's not your area of expertise. And then for those who may be family members or others who don't treat patients with these issues, we also want you to know more about what the challenges may be, what treatment may look like, because that also can increase the likelihood that those folks ask the right questions or are thinking about the right types of issues when they're involved, either as a family member or somebody who works with somebody with these problems. So again, when we think about this concept of people having more than one disorder, having a substance use disorder and psychiatric disorder, the numbers are huge, right? So I try to keep it as simple as possible. When we talk about co-occurring psychiatric disorders and substance use disorders, got 7.7 million adults. And we're talking about from the data from a recent paper by Han et al., which was in Health Affairs, which is a major journal. And so we also know that, again, if you treat patients with either of these problems, you know that these disorders don't occur in a vacuum. It's very rare that somebody walks into our clinic at Beth Israel and they have only an alcohol use disorder. It's very likely that there's some other issue going on, and that could be a psychiatric disorder, could be serious medical comorbidity. So there are multiple issues that we have to deal with. And as you can imagine, the more issues that are present, the level of severity that they may have increases the degree of difficulty, unfortunately. And so again, when you look at the data from the Han paper, almost 40% of those with substance use disorders have a co-occurring psychiatric disorder. About 18% of those with a psychiatric disorder have a substance use disorder. And I think it's interesting to think about that, because I think for those of us who treat these patients, if we had to guess what those numbers would have been, we probably would have thought that those numbers would be higher. And I think that one of the reasons that maybe the numbers are a bit lower is because we also have to recognize one of the important realities of treating patients with substance use disorders, that most people with these disorders, they don't seek treatment. They don't want it. They never come in, right? And so a fair number of these disorders may resolve on their own or not, but at the end of the day, we don't see these folks. So the people that we do see are usually the folks that have more severe disease, frankly, and that has risen to the level where somebody close to them or their primary care doctor has recognized this and said, usually multiple times, hey, we need you to see somebody who is an addiction specialist, right? And so in our practice, it's very common for us to get a referral, and then the person is ambivalent at best. They're not really sure if they want to do it. They may not come in right away, and that referral has to take place multiple occasions. So by the time somebody ends up seeing us, we have to recognize that those are sort of a self-selected group where the degree of difficulty is often very high. The disease that they may have, the comorbidities that they may have, may make it such that this is going to be a complex case, certainly. And then when you think about these folks and whether or not they get what they need, again, when you look at the data, less than 10% of these folks actually get treatment for the disorders that they have. Less than 10%. So that's shocking. So we need to do better. And then half of these folks, they don't get any treatment at all. So I think that really resonates here and really underscores the gravity of what we do. So I think by virtue of you being on the call, you've got some connection to folks that have these disorders. And this really underscores the importance of this work and really trying to get it right. And so that hopefully lends itself to a productive conversation moving forward. So I'll take the next slide, please. So when we think about these patients, there are huge barriers in place. There are many reasons that, as we saw in the last slide, that more than half of these folks with a co-occurring substance use disorder and a psychiatric disorder don't get the help they need, right? Cost could be one of these issues. Insurance certainly becomes an issue many, many times. We're often wrangling with insurance companies to try to get the level of treatment that we think is appropriate. A lot of times these folks aren't aware of resources. So as somebody who treats people with addiction, a lot of our time is spent out in the community trying to educate folks, because there is a alphabet soup of levels of care. And if we who do this every day have a tough time keeping track, I can tell you for sure that the trainees that we work with, the people that we are working with on a daily basis, it's very hard for us to keep track of levels of care, partial hospital program, IOP, intensive, et cetera. So think about that if we're doing this every day, how can you expect a family who's never had to deal with this before to know what should happen? And so that, again, underscores the importance of what we need to do. A lot of people who have these problems, they don't think that treatment's necessary, right? They don't want it. So they're ambivalent at best. The next bullet, as you see here, barriers to why these folks don't do well. Well, think about it. Again, they've got multiple issues going on at one time. So they can have a psychiatric disorder, co-occurring substance use disorder. Maybe they have advanced medical comorbidities, which could come into play at any time, right? You may be making progress in one area in treatment, and then their diabetes becomes out of control. So at any time, a wrench could be thrown in the plans here. And so social issues certainly as well. Or you could have a pandemic occur, certainly, right? And so I think it's very relevant for us today to think about it. The vulnerable populations that we deal with, as we've seen, and I'm sure you've seen too, are the ones who probably most likely to be thrown asunder by the pandemic and the coronavirus, right? Very anxious about what does this mean? People who don't want to come in and get treatment. Unfortunately, we've been able to adapt in some ways with telehealth. But again, I think we've seen many, many patients who have been set back. I can think right at the top of my head, a patient who had 18 months of abstinence, and again, all that down the drain when something like this happens. So we have to think about these folks, how they're very, very fragile in many ways. So at the end of the day, the last bullet here, there's a high degree of difficulty. And the reason why I mentioned that and why it's so important, because when we're supporting our colleagues who are trying to treat patients like this, I think they have to be realistic and allow themselves and allow their teams to come to grips with the fact that these patients aren't going to do well all the time, right? You may do everything you can. You may make multiple attempts to try to get somebody in the appropriate program, but they may not be ready. And so that's hard to see. And it's hard to see people not do well. And we have a patient who, on our team who, we've spent over a year with, and we've made valiant efforts, I think, to try to get this person in the right treatment scenario. And this person has done well over time, but they're more recently in the ICU for a variety of problems. So we have to come to grips with that. And that's hard, right? It's hard to work so hard with patients like this and to see a lot of them not do well. And that's why on my team, we try to emphasize when people do well to celebrate that, right? Even the little victories are really important. It's enormously gratifying to see that, but we really want to place an emphasis on that. Next slide, please. So these patients, again, labor intensive. So what does treatment look like for them? I think it starts with a thorough evaluation, certainly, that it takes a lot of time. And so when you say that and you think about our current healthcare industry, you understand that it's hard for these folks to get a real thorough evaluation, right? It's hard to have somebody have the appropriate amount of time, because when they see their primary care doctor, they see a specialist, everyone feels busy. And so these things are often rushed. And so when you think about somebody who's had problems brew over a period of years or decades, sometimes it's going to take time really to evaluate the extent of these problems, to understand the psychosocial issues that may be in place. So that evaluation is so important, and it's hard to come by, frankly. And so when we do that, we have to really see that there's really two columns at least, the problems that we see and the problems that the patient sees, right? A lot of times, especially when it comes to substance use disorders, they do not see their use of a particular substance as the major problem or a problem at all. And so if you're going to try to create an alliance, and you see the second bullet here, which is really the most important thing you can do, I think, in the initial evaluation, is try to create that alliance. Because again, if you know everything that you want to do for this patient, you know the medications that we're going to talk about inside and out, but if you cannot establish an alliance with that patient, they're not going to come back. So the rest of it is somewhat irrelevant, right? So you have to try to understand from their point of view what the major problems are. And so you can still approach substance use disorders in a skillful way, even if the patient does not think that's a problem, right? And part of that is motivational interviewing, and that we could talk a little bit later, but it's important to understand what they see the problem as. I think my major problem is my depression. It's certainly not my cannabis use, that kind of thing. And we treat all of these issues, right? You're not going to say, hey, we're going to address your alcohol use for the next 3 months, and then we'll get to your anxiety disorder. You have to treat them all at once. And again, so now you've got a very significant problem list that you have to deal with. So moving on to the second bullet, we talked about alliance. I think, again, actually, we're back to labor intensive things. Communication is so important. So I had mentioned earlier that people feel so busy, and there are a lot of steps that are very necessary that don't happen, right? And so for those of you who treat these patients, how many times have you had your patient go into the hospital somewhere, perhaps stay for a week, and you didn't even know about it, right? So that speaks to the fact that communication often doesn't take place. So we want to do a great job, perhaps even think about it as over communicating with family members and other treaters, because everyone has to know. If my patient goes into the ED, I got to know about it, right? I'm prescribing medicines usually, so I need to know these things. And then finally, in the second bullet, the last piece here is biochemical verification of substance use. And so when we're treating substance use disorders, if you're trying to help somebody with their opioid use or their alcohol use, it's imperative to use lab tests, frankly, to just verify what they're telling you. I want patients to be able to tell me what they're doing, but the data are very clear that self-report in substance use disorders is not worth a lot, right? So we have to have that on the table, that we know that I'm going to be testing you regularly, so that, again, I want you to tell me the truth, but I'm also going to test, right? You have to have multiple data points, and they include self-report from the patient, communication with other family members, and biochemical verification. So at the end of it, you're going to have a comprehensive treatment plan that is multifaceted, usually includes behavioral interventions that could be individual therapy, group therapy, mutual help groups like Alcoholics Anonymous or Smart Recovery, and then also the medication piece. And they're equally important, frankly. I mean, it depends, really, looking at the data, depends on the disorder, but for the most part, they're almost equally important. So as much as we're going to focus on talking about the medications today, that if somebody is not doing the other pieces, if they don't have a therapist, if they're not getting additional supplemental supports from the community, then in some ways it's almost asking too much from the medications, right? A bottle of naltrexone alone is not going to solve the problems for somebody who has alcohol use disorder for the most part, right? And that's really what we've seen. So it's a comprehensive plan. And once you come up with that plan, you need to be crystal clear about what that is with everyone involved. And I want to, again, emphasize the fact that when we do this, a lot of times patients don't want to do what we want them to do right away. And so that's part of the dance that takes place here. If we've created that alliance with the patient, they understand what we want them to do, they don't want to do it, at least right now. If we've created that alliance, hopefully at some point down the road when they're ready to do what is needed, they'll come back, right? So it's so critical to build that alliance and to understand that more than likely, they're not going to be ready to do it right away. So you may be struggling with that. I want you to know we do the same thing, right? It's a challenging endeavor, just like you have to convince yourself perhaps to get out and exercise, or you have to try to convince your 9-year-old to do math homework, right? I mean, I can speak to that. This is challenging too. And so part of it is just to try to be clear about what we think should happen. And if you do this a certain way and the patient begins to recognize, hey, this person really cares about what happens to me, and perhaps this team is approaching things in ways that are different than that I've had elsewhere, I think that increases the likelihood that they will ultimately do what's needed. And so for those reasons, a lot of these patients can do well, but it takes a lot of time and a lot of effort. Next slide, please. So let's move on. So the big three I mentioned earlier: alcohol, opioids, and cannabis. And we'll just briefly talk about the medicines that are available for each of those before we move on and take questions from the audience. And hopefully we'll have time to answer all possible questions. So alcohol use disorder, not talked about a lot, right? I think people have talked a lot about the opioid epidemic, which is incredibly important. Patients are dying every day. Cannabis is kind of an eclectic topic, and people like to debate that. It's very controversial. But all the while, patients come into us and they've got alcohol problems. It's as dangerous as ever. And these patients do die as well, right? They may die in different ways. It may not be as dramatic as in some other cases, but if we can't get their drinking under control, they will run into liver problems, they may fall, etc. So this is really a life-threatening condition. So when we think about the medicines for alcohol use disorder, there are 3 FDA-approved medicines: disulfiram, or Antabuse, is probably the oldest. It inhibits a enzyme, aldehyde dehydrogenase, so that if you are using this medicine and you drink, you will get sick. So it's sort of an aversive therapy. And for that reason, not a lot of patients ask for this, but there are cases where it's very, very helpful. And usually the ones that we think about are the ones where there's a family member or a spouse who's intricately involved with the treatment. And it can be a way for that person to administer the medicine every day and to sort of set the stage each day. Okay, this person is going to do whatever they need to do today for treatment. It starts with taking this medication. So it can be very helpful. And I've treated a lot of patients who are very motivated, and that's been a very helpful piece for them. Naltrexone is the second medicine. It's an opioid blocker antagonist. It really reduces some of those warm and fuzzy feelings that you get when you drink. And so that can be used usually on a daily basis to reduce that euphoria that you may get from drinking, also reduce cravings. It's available in multiple formulations now. So there's an oral pill form, is also an injectable form that we'll probably talk about in a minute with opioid use disorder, but either one is fine depending on the patient. I like this medication a lot, and I will say, again, if you're doing all the other things that are necessary, then I think this medicine can help a lot. I would just say one more thing about naltrexone before I move on is that it's chronically underdosed. So it's often appropriately started by primary care doctors at 25 or 50 milligrams, but the data are pretty clear. There's a paper by Petnati et al. That was in American Journal of Psychiatry in 2012 that showed that patients with co-occurring disorders like we're talking about, in that case, MDD, major depressive disorder, and alcohol use disorder, the average effective dose was about 100 milligrams. So it really needs to be managed. These aren't set it and forget it kind of medications. Finally, acamprosate is a glutamatergic medicine that really dampens some of the anxiety that some people have around drinking, and it can be effective. Was effective in multiple European studies. You do have to take it 2 or 3 times a day, so that's a challenge, but it's a good tool, right? And so with any of these medicines, I think that you have to think about the patient and what will work best for them. It's not about what you prefer or what you feel comfortable with. It's really about the clinical scenario for each given patient. Next slide, please. So moving on to opioid use disorder. So these medicines of the alcohol use disorder and cannabis use disorder, the medicines for OUD are the most effective. So the data is rock solid here. So one paper that I always like to talk about, Roger Weiss from McLean did an incredible study with the Clinical Trials Network, and they looked at buprenorphine, which we're going to talk about first bullet here. Buprenorphine is a mu partial agonist, so it's sort of a half opioid agonist, provides about half the effects of methadone, for example. But in that study, patients who went in and were quickly tapered off of buprenorphine, as is very common in most hospitals, that if you were to go in and do an opioid detox in the hospital these days, you'd likely be tapered completely off of whatever medicine they put you on. Those folks who were tapered quickly, 6% of them were opioid-free, illicit opioid-free at 3 months, whereas those who were maintained on buprenorphine, 49% of them were illicit opioid-free, and so about half. So you may think that's a good number or a bad number, but at the end of the day, it's a substantially high number than those that don't go on the medicine. So patients with OUD, they really need the medicine, and that's really where the data has shown us. So buprenorphine, again, often has naloxone on it as well to decrease the amount of diversion or injection with those medicines. Also available in multiple formulations. There's an injectable form now that's available. Methadone is the old standard Schedule II medicine, and if you're using it for opioid use disorder, it has to be given in a methadone clinic, so patients have to go every day in the United States. It's not true in the UK, but you have to go to a clinic, and so for some people, that's good. That structure that a methadone clinic provides is very helpful. So methadone, we recommend it for a lot of patients who have usually had multiple treatment episodes. And then finally, naltrexone. So the injectable naltrexone form is manufactured and sold for opioid use disorder. And again, I think it's an important tool. We offer them all, really. We offer access to all these medicines, and some patients like that. Any injectable form of medicine, the argument's going to be made that the patient's making a decision once a month about whether they should take their medicine versus 30 or 60 decisions. And so that's an advantage in that way. And then finally, we'll move on to cannabis use disorder. Next slide, please. So for cannabis use disorder, importantly, there are no FDA-approved medications. And so this is an area where I've done some work over the years, some small clinical trials looking for pharmacotherapies for cannabis use disorder. There are no FDA-approved medicines. But what can we do if a patient has cannabis use disorder using multiple times a day, they can't stop, and hopefully they're doing all the other things, they're having their mood addressed, they're seeing a therapist. In those cases, we'll try usually one of these medicines. So N-acetylcysteine is a glutamate modulator. It's been studied extensively by Kevin Gray at South Carolina, who's one of the top researchers in the field. And so he had a positive study that came out, American Journal of Psychiatry also, around 2012, and it was in adolescents. And what they found was in adolescents who were taking NAC, and they also were doing contingency management where they were awarded or rewarded, for going to treatment more or less. Those folks who got the NAC and the contingency management were 2.4 times more likely to produce a negative urine screen for cannabis. So that was a very positive study. It was not replicated in adults, but I still think it's worth a try because the side effect profile is essentially minuscule for N-acetylcysteine. The second medicine, gabapentin, that you may know, it's FDA approved as an adjunct medicine for seizure disorders. It's a GABAergic medication. It inhibits calcium channels. And there was a positive study by Barbara Mason on the West Coast in 2012, Human Psychopharmacology, where they used 1,200 milligrams of gabapentin a day, and they reduced cannabis use significantly. So that's also worth trying, particularly if the patient's already taking gabapentin. That's when we'll often try that. And then finally, cannabidiol CBD. It's very hot. If you go to any corner store in your neighborhood, you probably see it being sold. So there are a lot of problems with cannabidiol, I'll say, but there are some studies that show that this can be a tool perhaps to use for patients with cannabis use disorder. So the mechanism of action is not really clear. There are multiple mechanisms, but I would say that's an option. I just want you to know what the options are and really want you to hopefully go to an expert to use these medicines, but these are options. And I'll take my final slide. Overall, we did a nice introduction, hopefully, with the medicines. We talked about the problems that people face. I think it's important to be comfortable treating all kinds of psychiatric disorders, right? It doesn't have to be your area of expertise, but so many people have all these disorders, multiple disorders at a time. We want you to feel comfortable. So we still want you to be able to call somebody and ask questions, but we don't want you to avoid entirely treating patients, particularly with SUDs, because we need these folks to get treatment. Never worry alone. Always know where to go. And that's really the point of a session like this. We want you to feel as though there are resources available should you treat a patient with an SUD and a co-occurring psychiatric disorder. Second bullet, I think it's so important to give yourself a break in some ways and understand that this is really difficult. A lot of people don't want to deal with patients who have all these disorders. And so it's a very select group who are willing to really battle on a daily basis to try to help these patients. There are a lot of ups and downs, unfortunately, but I think it's important to understand that it's an uphill battle, but it's very much worth doing because finally the third bullet here is that these patients can do well. They really do. A lot of times they may have had multiple treatment episodes before, but if you treat substance use disorders, you know that the quality of care is variable, highly variable. Some places really don't practice evidence-based medicine. They don't use the latest. They may be, we talked about medicines for alcohol use disorder. Some treatment facilities don't use any of those things. They feel like, we're not going to trade one drug for another, that kind of thing. And that's really not based in science at all. So because of the fact that the quality of care is so variable, if they come to you and you're doing everything right, it may be, a chance that they haven't had before. So these patients can do well. And when they do, as I said before, it's enormously gratifying. So with that, I think we'll start taking some questions. Thanks.
Thank you very much, Dr. Hill, for that very lucid review of a vast field within a short time. We have had a few questions that have come ahead of time, and maybe we could start with them. And I have a couple of my own questions, and then we can look at what is coming out in the chat box and any other questions from the audience. So the first question that I have here is actually a very important question, which I have myself faced in practice. And Dr. Hill, I'm sure you have some words of wisdom on this. So this question is the following. For new onset psychosis likely triggered by heavy cannabis use, how long should an antipsychotic be continued after the resolution of psychosis, particularly if the patient has stopped using cannabis? I have had several scenarios in which it is unclear if the psychosis resolved because the patient stopped using cannabis or whether it's because they're on an antipsychotic.
So thanks for the question. I think that's an incredibly common scenario that we encounter. Just to take one step back, when we talk about cannabis triggering a psychotic disorder, the data is crystal clear that if you have a family history of a psychotic disorder, that being schizophrenia, schizoaffective disorder, bipolar disorder with psychotic features, you're more likely to express that if you're using cannabis regularly, especially at a young age. So we're not saying that's a causal relationship, and people debate that, but there's a clear, increased likelihood. If you look at there are over 10 large studies that have looked at it, and so the odds ratios are essentially from 2 to 5. So you may be 5 times more likely to express one of these disorders. And so as we're talking about here, we see this clinically very frequently. It could be a young person who has used cannabis for 4 months and now they're on a locked unit and they're psychotic, and people have started an antipsychotic medication, that type of thing. Sometimes the psychosis does resolve. In my experience, most of the time it does not. So it's often a very challenging, sad scenario where somebody, again, this may have occurred without the cannabis use. I mean, it's hard to know, but at the end of it, they're kind of starting a period where there is sort of a downward drift. And so we'll often try to convince these folks to take medications. I'm a big advocate for psychosis for using injectable medicines because of the adherence issues. But, I would say there really isn't a set time to take the medicine. In my experience, the patients, their psychosis does not resolve completely, and they may do well on the medicine, and they may stop using cannabis for some periods of time. And I can think of a bunch of patients off the top of my head where they every time they go back to cannabis, the worsening psychotic symptoms follow. So, if that patient's doing well and everything's going great, I wouldn't be averse to trying to taper the medicine. But in my experience, we've started a long path. And it's often a very frustrating path where we're constantly trying to get the person to take the medication that they need for psychosis. It's not something that should be taken lightly. Again, trying to educate young people, if you have a family history of psychosis, that your cannabis use can be especially dangerous for that group.
Yeah, thank you. That's very, very clear. But there are going to be some situations, as I have seen in my own practice, patient comes in with heavy cannabis abuse leading up to a brief psychotic episode, no family history, and then the psychosis clears up completely with an antipsychotic. Would you say that if the patient is stable for a year or two, then it's reasonable to consider a tapering of the antipsychotic in such a situation?
Yeah, definitely. Yeah. And so on my team, we're always talking with patients about when they're going to come off of medicines, right? And then we may not even be close to really considering it. But I think it's so important to talk with patients about the idea that, hey, I'm not prescribing a medicine for you that I'm intending for you to take forever. I hope you don't have to. So I'm open to that. Whether it's medicines for OUD, like buprenorphine, I would like to entertain the thoughts of them coming off. And we will frequently try to get folks off. So the patient that you described, I'd be more than happy to do that. But I want everyone involved to be crystal clear on when we start tapering that antipsychotic, that we need close contact just in case it doesn't go well. And so in very controlled circumstances, I'd be absolutely willing to start tapering the medicine.
Great, thank you. So the second question that I have here, which actually is a question from me. I see a 26-year-old man with schizophrenia and alcohol abuse who is stabilized from both the conditions for over 2 years. He's asking, Doc, can I have an occasional drink with friends or family, like on July 4th or Thanksgiving or Christmas or New Year? And he has read about this so-called controlled drinking as an option. So what do I tell him?
I would not want to encourage that, but I will say, and I think it's so important to be honest really about what really happens in the real world. Most of the time, there are a lot of times when, and I've got a bunch of patients, I've been doing this for a while now, and I've got patients who have had really serious alcohol problems, multiple detoxes, et cetera, and then they were abstinent for an extended period of time. I'm talking over 10 years. And these patients like to stay in touch with me, and some of them have gone back to drinking occasionally. And that worries me, certainly. But these folks have done okay. They're still married. They're still working, et cetera. So I would not endorse that. And I would be clear. I would be worried about it. I would prefer you didn't do it. But sometimes people do that, right? Just like we mentioned at the top, where sometimes people who have alcohol use disorder, they never see anybody like us, and things resolve on their own. So it can happen, but I'd be concerned about it. Similar to when people talk about drinking, non-alcoholic beer and things like that. I just think it's a slippery slope. And so while I understand it's not impossible for people to have a drink or two, it just seems to be taking an unnecessary risk. And that's really the conversation that I would have.
Thank you so much. The other question I have here, which is in the area of substance abuse, is I have a patient who is convinced that the type of cannabis which has high CBD keeps him well, even from his psychosis. And he's only willing to take an antipsychotic if he is allowed to continue his brand of cannabis regularly. He claims that he gets it from the store. What do we tell him? What's the evidence of CBD having any therapeutic effectiveness for psychosis?
It's a great question. So there is evidence. There is evidence to support the use of cannabidiol, CBD, as an adjunct medication for psychosis. It's not uniform. So there have been now a handful of randomized controlled trials, and the results are pretty much mixed. So there is some evidence. And when you think about it, when you think about the cannabis plant and the fact that the major two cannabinoids, so there are over 140 cannabinoids, the major two cannabinoids that we're concerned with are THC, delta-9 tetrahydrocannabinol, and CBD. CBD functions as a buffer of sorts to THC. And so when you think about that as sort of a yin and a yang, what does THC do? THC is responsible for psychosis that some people have. And so with CBD being a buffer, you can appreciate the fact that, okay, it seems to have some antipsychotic properties. But I think in this case, what I would try to talk to the patient about is, well, is there I'm okay with you taking CBD, but is there a way that we can have you take pure CBD or CBD with negligible amounts of THC? And so we have to be, when we're talking with patients who have these kind of questions, which are great questions, I think it's so important to see what they're using and to talk to them clearly about what they're using. A lot of times people talk about high CBD strains of cannabis, but they also have high THC content. So I think personally, in looking at the data, and we mentioned there are significant problems with CBD that a lot of people don't talk about, but there also is a lot of promise. And to treat psychosis as an adjunct, there seems to be some promise there. Hopefully we'll learn more, but there are some papers, and again, send me an email, I'm happy to direct you to them. So that, again, the data are mixed, but there is some positive evidence supporting the use of CBD as an adjunct treatment for psychosis.
On that note, Dr. Hill, there is this medicine that is used for special kinds of epilepsy, Epidiolex.
Yes.
Would you prescribe something like that in people with cannabis use disorders?
I would. So Epidiolex is pure CBD. It's FDA approved for 2 pediatric epilepsy disorders Dr. Keshavan mentioned, Lennox-Gastaut and Dravet syndrome. So in my practice, we have tried multiple times to use this in cases like we're describing, where we can make a good case for using CBD. The problem is that Epidiolex is prohibitively expensive, and insurance companies will not cover it. We have not had any, and we try, because again, and this gets to one of the great debates when we talk about cannabis. There's actually an outstanding editorial in American Journal of Psychiatry just over the weekend by Kathleen Brady. And so people like Dr. Brady talk about preferring FDA approved medicines where they're control. We know the purity, the potency. I prefer them as well. But the problem is insurance companies won't cover that. So 95 or greater % of CBD that patients use is not FDA approved. And so you have a difficult predicament where as a doctor, you have to decide, are you willing to try to help them use CBD that's not FDA approved? And that's a question that everybody needs to ask. So theoretically, I would love to use Epidiolex in any case where I thought CBD was warranted, but we've tried it many, many times, and we've battled insurance companies. Matter of fact, we did one round of denials with an insurance company. They actually cited one of my papers. So it hasn't worked yet. We just haven't been able to do that. Perhaps down the road, if the cost comes down or somebody else comes out with a form of CBD. But to this point, we have not been able to take advantage of Epidiolex because it's prohibitively expensive and insurance companies won't cover it.
I'm sure there will be a time when it will get off of the period of time, right? When it is still patented.
True. Yeah. And the company that made it, I actually studied CBD in a small clinical trial, and I worked with that company, and they made no bones about it. They were not interested in marketing it to the patients that we treat. They were interested in marketing it to a small group of people who had this very rare seizure disorder. So yes, you're right. Hopefully it will come off patent at some point, and it'll be available, and we'll be able to use it more safely than we are right now.
Yeah. So the last question I have here in the area of substance use disorders, I'm sure there are others from the chat box. So the question is, you mentioned N-acetylcysteine or NAC for cannabis use disorders. Does NAC have benefits for psychotic disorders as well as for other psychiatric disorders?
Great question. So, where's the evidence for those disorders? I'm a little less clear on it. I know for sure that there are a lot of clinicians who use it, and I think they use it for a lot of the same reasons that I do, that for the most part, the side effect profile is largely benign. So if a patient, like I said, is doing everything else, and there's a question of should we try a medicine, that's a good medicine to try. So I can't cite you the evidence on psychosis, but I do know that NAC is widely used for a host of issues. I think skin picking and maybe, people pulling out their hair, trichotillomania. But so it could very well have some data for psychosis. I'm just not aware of what that is.
Yeah. Well, I could add here that we did a study at Beth Israel Mass Mental a couple of years ago, a small clinical trial of NAC in the early course of psychotic disorders. And we did not find a clear-cut difference from placebo in terms of therapeutic benefits as a whole for this compound, N-acetylcysteine. But in this subgroup where there were alterations in a particular biomarker, namely the levels of glutathione peroxidase. So this compound, N-acetylcysteine, is an antioxidant. So those who have evidence of what we call oxidative stress, in that group, NAC actually had some benefit. So again, there is more research to be done, but this may be a very interesting medicine for further research. And certainly, as Dr. Hill said, because it is safe, it's a nutritional compound. It has negligible side effects, so it's something of interest for future research. I have one question here that is not related to substance abuse related issues, but this is generally a psychopharmacology consult session. We do take those questions as well, and I'll briefly raise that. And I can answer that, and maybe Dr. Hill will have some thoughts on that as well. So the question is, my son's psychotic symptoms are well controlled with Abilify, but his weight gain is a source of considerable stress to him. As a parent, I am concerned too about long-term health issues. Is there a medication that can help with this? So first of all, I want to say that all atypical antipsychotic drugs can cause a little bit of weight gain, but some more than the others. Some, such as olanzapine, clozapine, and quetiapine, are more likely to cause weight gain. And some others are actually relatively a bit more weight neutral. Aripiprazole or Abilify actually comes under that category. Even though even Abilify in some people can cause a little bit of weight gain, between 5 to 10 pounds, that kind of weight gain. So this parent is understandably concerned even with that level of weight gain, because we don't know what the long-term health issues that might be related to this sort of weight gain, metabolic syndrome, and the risk of diabetes and so forth. So my thoughts are, number one, in such situations, one could consider another antipsychotic which may be weight neutral. And one such is ziprasidone, and the other one is lurasidone, both of which have a reputation of having low weight gain propensity. The second important point that I would say is that in everybody who has this issue of weight gain, you have to look at lifestyle, calorie intake, exercise, and get a program instituted where the person regularly monitors one's own weight and and other indices of weight gain, such as weight circumference, abdominal circumference, and so forth, and a regular exercise regime. The third thing is, this is not an FDA-approved indication, but there is some evidence, including a double-blind controlled trial by Chris Correll recently, which has shown that metformin, which is a diabetes medicine, when combined with an antipsychotic, can actually help with weight gain. But again, I'm saying this, it's not FDA approved for this particular purpose in people with psychotic disorders who are on antipsychotics, but clinicians do use medicines outside of FDA indications sometimes when no other options are not working, and metformin is generally has a relatively benign side effect profile. And there are other weight medicines as well, but I'm not going to go into the details of that. Dr. Hill, do you have any thoughts?
Yeah, I do. I mean, I really think that the second piece that you said is the most important here, to validate really the issue for the patient and the family. That you're talking, again, the people tuning in here that treat psychosis more than I do probably, but you're using tools that are going to cause weight gain. And that's why the treatment adherence issue comes to the fore always. And so as Dr. Keshavan mentioned, I think it's so critical right up front to have a frank risk-benefit talk with the patient and the family about this. You know, this medicine, yes, these are the risks. And I also say this treating patients who don't have psychosis, who are put on these medicines, quetiapine, 25 milligrams to sleep and things like that, who don't know what the risks are. So this informed consent often does not occur, unfortunately. But in this case, if you have psychosis and the medicine like Abilify is being used, and I think right away we need to emphasize the point that this medicine is critical in order to stave off psychotic symptoms. And these are what the potential risks are. And because we know that, then we need you to see a dietitian, or we need to talk about exercise as Dr. Keshavan did, because that's really the crucial piece here. I've got, and I'm sure everyone does, I mean, you've got patients who use these medicines, they have to work extra hard to keep weight neutral. But people do it because some of these folks recognize that if I don't take this medicine, then things are going to go off the rails. And so it's an unfortunate position where the good news is if you take the medicine, it's probably going to control your psychosis. Unfortunately, there are a lot of potential side effects that come with it. And that's really the crux of the issue in the patients that we treat that have psychosis. And that's why I mentioned injectable medicines before, is that adherence almost always becomes the major issue, frankly. And that's why I want to put all the cards on the table and say, look, we're going to do whatever we can to try to mitigate these side effects. And sometimes you can, and sometimes you can for a while, and then, but eventually patients often say, look, I don't want to take this medicine anymore. I mean, it's making me gain weight. I'm developing breasts or things like that. So I think it's a great question. And I think, I feel for the family. And I know that it's hard because the family probably recognizes, they're doing the best overall with this medicine. What can we do to have our son continue to take it? That's just it's a difficult spot to be in.
Yeah, thank you. Yeah, one other thought there is that there is the perception, with some data among clinicians, that injectable maintenance antipsychotic medications may end up needing less overall doses of the medicine than oral medicines. And so Abilify, aripiprazole, is available as a monthly injection as well. It's called Abilify Maintainer, something worth considering. If the psychosis is well controlled and the weight gain is an issue, this might be something to bring up with the doctors. So those are the questions we have. Rachel, do you have any questions from the chat box? There's one that I have here.
So we have two additional questions. The first is, why are a few MDs still supporting legalization, commercialization of high THC products? Do you see differences in the recovery of patients using the old-fashioned low THC pot versus today's higher THC marijuana?
So should I take that? Why are doctors supporting that? I'd say most doctors are not supporting it. I mean, I think there are a few outliers, but in terms of patients and what they use, I think we need to recognize that it's very hard to find low THC cannabis akin to what was available in the 60s, 70s, and 80s. So the average THC content in those years was 1 to 4%. And, if you go to the local dispensary, there's one less than a mile from our hospital that has a line outside of it every day, all day long. If you went into that place, you're not going to be able to buy, I don't think, THC content of 4% or less. So what people are getting is high THC content. And again, the problems that you can see with cannabis are more likely to occur. It's dose dependent. So they're more likely to occur if people are using high percentage THC products, and they often are using them frequently. So it's kind of a topic for another day. But there are potential medical benefits for some cannabinoids, but there are a lot of problems too. So it's not a simple issue. And again, each clinical scenario is different. It needs to be explored with a professional.
And then the next question is, what are your thoughts of using Vraylar for AUD plus EPD2? I've had a few positive results.
Yeah, I have not used that medicine. It's a newer medicine, so I'm not familiar with studies on it. So, if you have a new expensive medicine, we have 3 medicines that are FDA approved for alcohol use disorder. I suppose if you exhaust those, and there's a few others actually, topiramate has some studies. So there are a lot of tools to use for alcohol use disorder. I wish they were better. So, I think if somebody works their way down, perhaps they could get to a point where they would use that medicine, but I have not yet.
Well, for those of you who are not familiar, Vraylar is cariprazine. It's one of the more recent atypical antipsychotic drug. I agree with Dr. Hill. There is no empirical data yet on the use of cariprazine in substance use disorders comorbid with psychotic disorders. But clinical experience, one should always listen to clinicians and collect more data on those kind of interventions. There's one last question here, unless Rachel, you have any other?
I don't see any so far.
One last question that I had received is, can you comment on treating special populations such as physicians with substance abuse in respect to treatment? It's kind of a broad question.
Yeah, well, that's a very interesting question. So we do a lot of that. So I treat a lot of special populations, healthcare professionals, athletes, pilots. So the good news when you talk about some of these populations, including physicians, is that they're motivated. They're highly motivated. And generally speaking, they do really well. So a lot of, the treatment itself often looks similar. I mean, they're same components. If you need a detox, you do a detox. They're often mandated to do residential treatment for 30 days, which is a little different. So they're getting more treatment. And once they leave that residential program, then they're monitored. They go, whether it's physician health services here in Massachusetts, depending on what state they're in, but they're being monitored. So all the pieces that we talked about before, they have a therapist. Other co-occurring disorders are being addressed if they exist. Biochemical verification. So these folks are drug tested at least monthly, randomly. So those patients do well. And so the same is true with pilots, for example. So those groups, you have to understand, these are highly intelligent, highly motivated patients. And if you say you do these 15 things and you'll get back to practice, a lot of times they do those things. So for the most part, that's a population that does really well with treatment, I would say.
So what you're saying is external incentives, like getting back to practice, are a very powerful motivator.
Absolutely. Yeah. And just to say one last thing, kind of getting back to the evaluation, I mentioned motivational interviewing. So when you're talking with a patient, and you, as Dr. Keshavan mentioned, you have to try to figure out what their motivation is, right? And sometimes it's easy. Like, I want to get back to practice if they're a physician. But a lot of times with a young person using cannabis every day, it's not so easy. But you have to take the time to figure that out, because their one reason for making an effort is better than 10 reasons that I could give them. So you have to figure that out early in the treatment.
So I think we are at the end of our time. Thank you very much, Dr. Hill, for really very insightful discussion.
Thanks for having me.
Yeah, thank you. Rachel, do you have any last minute items that you want to cover?
So there's one more question, but I can email it to both of you, and then we can send it out later. But other than that, thank you all for joining us today, and you'll be receiving an evaluation form for this event right afterwards. Thank you.
Thank you, and have a good afternoon, everyone.
Take care, everyone.